I have actually two good news. One, I'm happy about. One is we had a child psychiatry match today. So we matched and we got really 3 good applicants. So I'm very happy about that. And secondly, we have Dr. Leon presenting today. She will be speaking on autism spectrum disorder screening instruments and the development of screen for social interaction. She doesn't have any financial disclosure. I just want to make sure I say that before anything else. And I can give you brief background information. She did her BA in psychology from Bowling Green State University, and then MA in psychology of intellectual and developmental disabilities from Ohio State, and then she did her PhD from Ohio State. And she's presently consultant at counseling and consulting services. She has done, some research and also written papers. I'm especially kind of pleased to have her here. She came from Ohio State. We have connection with Ohio State for some time. Dr. Michael Amon, he has been Jaswinder's mentor. And also that she was able to do some research on some of the data. Jaswinder has worked at Johns Hopkins and Kennedy, and they had developed this scale. So please welcome her. Thank you.
Thank you, everybody. Thanks for coming today and a busy week, a busy first week of January. So like Dr. Guman said, I've been involved with research and clinical activities with individuals with developmental disabilities for some time. And I'm currently a consultant at Counseling and Consulting Services, providing developmental behavior interventions, counseling, functional behavior assessments, psychological assessments for people throughout Southern Arizona. So I'm really pleased to be here today. And I will be describing a research project that was a collaboration with Dr. Jaswinder Guman, as mentioned, and 2 other colleagues from Ohio State and Kennedy Krieger, Dr. Luke LeCavalier and Dr. Rebecca Landa. And what we've done is developed a new set of screening instruments to be used with very young children to screen for autism spectrum disorders. We ended up with very brief, sensitive screens that detect social interaction behaviors, and we're pretty excited about the outcome of the studies. So I'm going to begin by covering some of the currently available screening instruments briefly. There's a lot of detail in these slides, and I know we won't be able to get to all of it, but I know some people are interested in some of the more statistical or methods information, so that's included there for you. You have 2 sets of handouts. One is a set of tables for those of you who are interested in more of the statistical or subject group characteristics, and the other is a copy of the actual SSI toddler and SSI preschool screen and scoring templates. So first, a quick background, a reminder about autism spectrum disorders in general, and then we'll look at screening versus diagnosis. Autism spectrum disorders include currently autism, Asperger's disorder, and PDD-NOS. As you know, it's likely to be changing with the DSM-5, where there's going to be a regrouping, possible elimination of Asperger's disorder, for instance, as its own category. Diagnostic criteria include significant delays in social interaction, communication, and presence of repetitive or ritualistic behaviors, as well as onset prior to the age of 3. The diagnosis from about age 24 months at this point is pretty stable. People try to diagnose anywhere in the range of maybe 18 months or higher, but right now the current efforts have stability from about 24 months. diagnosis often focuses on the 4 to 5 year age range due to the ability of children at that age to display the certain types of behaviors that are looked for, as well as their behavioral history and their developmental history. And diagnosis itself is very involved and requires a lot of time and resources. There may be people here who are involved in that and you're familiar with it. Some of the common measures include the ADIR, the CARS, and the ADOS. And some are a little more involved than others, but these are some of the standards that are used. And as I mentioned, as far as reliability or stability of diagnosis, there are efforts to improve that for younger children. For instance, the ADOS-T is a toddler module that is attempting to produce reliable diagnoses from the age of 18 months. And there are some promising results there. So I just wanted to kind of mention the diagnosis in terms of how it's different from screening. And I don't know if you're familiar with screening, but the basic of it is that you are looking for the risk of a certain disability or disease. It's used for disorders that do not have a clear biological marker and that may be prevalent in society that need to be detected. And with autism in particular, it's been recommended that children be screened at 18 months in order to identify and begin treatment. Screening, the accuracy of screening is generally judged in terms of these two indices here. I should use my mouse. Sensitivity and specificity. And these are really just proportions. You choose a cutoff for your instrument, however you've created it, and these are proportions of individuals that you've correctly identified versus those that you've incorrectly identified. And that's always the balance that you're trying to strike to get a high proportion of both. And with screening, you want to be looking for behavioral markers that can be easily identified with someone who's not really familiar with the disorder. You maybe have parents or practitioners who are not familiar with a particular disorder, and so you want it to be something that can be easily completed and filled out by someone who's not familiar. The outcome of screening may include referral to specialized diagnostic clinic, followed by any needed treatments. Okay, so just to mention this, there are a couple of different levels for screening. Level 1 is a general population screen, and this requires a larger sample of participants because you're looking throughout the general population to try to catch and detect cases of a disorder. So your base rate is much lower, for instance, in the general population for autism than it is for a specialized developmental clinic, for instance, where people may be coming in to get differential diagnosis for that disorder. And that leads to this concept of a level 2 screen that is a quick and easy way to screen in these specialist settings or in other settings where people may want to be referred on for more closer look. Okay, now let's briefly look at the highlights of some available screens for ASD. The modified checklist for autism in toddlers, the MCHAT, is probably the one that's most familiar to people, and it's probably the most used at this point. It's a level 1 screen. It's sometimes used as a level 2 as well for 18 to 24-month checkup, and completed by caregiver. Includes 23 items that are based on yes or no, whether the behavior is present or not. It includes things like questions like, does your child imitate you? Does your child make unusual finger movements near his or her face? So it includes social communication and repetitive and ritualistic behaviors as part of its screening. It was adapted from the CHAT, which is a British screen, and the CHAT is a 9-item scale that has additional items that are interactive or that are observed by a physician or a clinician. So that's not really used in this country as frequently. The MCHAT has a couple of different scoring methods based on whether the child has failed, as they call it, a few items or some of the critical items. And we'll get back to this concept of critical items in a screen. The MCHAT has had promising sensitivity and specificity scores, which again are the accuracy levels of the screen for identifying children at risk. Related to this, another instrument, the QChat, is a level 1 screen under development, attempting to get ever closer to a really good level of identification of these individuals. Something that makes this one different is that it's on a 5-point frequency scale rather than a pass or fail for each item, rather than a binary scale. So this allows for a little bit more sensitivity in detecting the presence of the behaviors. Some QChat items include asking about whether the child points to share interest with a caregiver, how long that the child's interest can be maintained by a spinning object, for instance, by spinning wheels, by watching something that's repetitive. How easy is it to get the child's eye contact? So you start to notice overlap in some of these measures because we're looking at the core diagnostic features of autism and trying to find the cardinal features that will best screen. So the QChat is still under development, but it's pretty robust and definitely worth mentioning. Another well-known screen is the Social Communication Questionnaire. And this is for children 4 years and older, although it has been assessed for younger children as well. These are based on the ADIR items, which itself can be a point of criticism because the ADIR is a clinician-administered measure, and some of the items are fairly complex or require some clinical intuition or subtlety that may not be as easy for a screening instrument that you're expecting a parent or a caregiver to fill out. So, but nevertheless, the STQ has been useful, and however, some of the specificity measurements have been called into question in some studies, and again, that means that you're getting a lot of false positives. So that's something that's being looked at with the SCQ. Okay. And an interesting and promising one is the STAT. And I don't know if you're familiar with this in your clinics here, but it's a 12-item interactive screening tool for children in the 2 to 3 age range. And it's pretty brief, but it's also clinician administered. So the clinician will set up interactive situations with the child and see how they perform with it. For instance, and the examiner will roll a car in front of the child and then say, do this, and see if they'll imitate. Or inflate a balloon and let it go and see if the child will attend to that as it's moving, that shared attention. And so the STAT's a pretty exciting instrument. It's the sensitivity and specificity have been very good in the studies that have been done on it. But there again, it requires that time and resource of having an expert clinician to administer it. And finally, I just wanted to mention some other instruments that are under development. The first-year inventory has 60 items. That's the initial set of items. I think they're going to be paring that down over time. So that's still under development. The DBC ES, the early screen, is a 17-item instrument with a 3-point scale for children in the, about little under 2 to a little over 4 years of age. And the psychometrics are, for the DBES, the sensitivity and specificity around about 0.75 and specificity of about 0.51 or thereabouts. So it seemed to be there's some specificity problems with that too. And again, not to get into too much jargon, but again, that just means there's a problem with some false positives in some of the studies that are being conducted with this. And the social responsiveness scale is a continuous scale of many, many items related to autism spectrum disorders. And it's not necessarily meant as a screen, but it's not quite clear what it's going to be, how it will be used clinically. They have found that the behaviors are normally distributed across the population, so that's promising with regard to epidemiology and phenotypic type of work. Okay, so we have these screens, but then what is still needed? You know, it seems like there are several available, and so not being familiar, what is it that we would still need? And there is definitely a need for attending to both sensitive and specific, i.e. accurate screens for very young children, with an emphasis on the basic cardinal features of autism, which is the social interaction abilities. And, you know, study after study has indicated that these joint attention, imitation, shared experiences, mimicking, communication, and play, these type of things are the markers that distinguish the autism groups from the non-autism delayed groups. So this, you know, the emphasis should remain on these. And another idea with this is that there may be some trouble including the repetitive or ritualistic behaviors in the screening instruments. This is not, there are lines of evidence for this. It's not necessarily the case that they should not be in screening instruments, but they do kind of muddy the waters when it comes to the fact that repetitive behaviors are often co-occurring with individuals with general delay, even with typical development. So it's not really a specific marker for autism or autism spectrum disorders, and it's possible that some of the problems with the specificity or false positives may relate to that. That's still a hypothesis, but it's something that there is research evidence for. So a few years ago, Dr. Jaswinder Guman and her colleagues developed a 54-item scale called the Screen for Social Interaction, or the SSI, with a concentration on this capacity for social communication behaviors. It's essentially like a level 2 instrument at this point that is completed by a parent or caregiver and has been evaluated for children in the 2-year to 5-year range. It includes, or it is scored on a 4-point frequency scale from the behavior occurring almost never to almost all of the time. And it's, one of the differences with it is that it, the higher scores with it will indicate more typical development. And that's because the items that were used are reflective mostly of typical social communication development. And with some additional items related to kind of almost the antisocial or the stigmatizing type of social behaviors that sometimes can be seen in children with autism spectrum disorders, such as the yelling or screaming, taking toys from other children, just not understanding those social rules. And so some items like that were also included in it, you know, to see how powerful those might be. And the items were developed from clinical experience, from adaptive behavior concepts, as well as diagnostic indicators. Okay, so the initial study of the basic diagnostic validity of the scale was conducted, or was published in 1998 with a group of clinical children and typically developing controls. And these clinical referrals here included individuals with PDDs or ASDs and or autism spectrum disorders, pervasive developmental disabilities. And this description of developmental concerns, some of these children may have had ADHD, general cognitive delay, disruptive behavior disorders, and other and speech and language disorders. So a nice heterogeneous mix of clinical individuals. The reliability levels were good to adequate for that particular study, and the initial diagnostic validity was looked at in terms of comparing a cutoff from the typical controls to the clinical individuals. And using that cutoff, they found good sensitivity and specificity levels for the younger and older children, of specifically 0.83 and 0.81 for the youngers, and 0.75 and 0.86 for the olders. So these are promising results, but there was a need to include more subjects and to have a finer discrimination to establish the SSI as a screen. So this leads to the section on the research that we conducted recently. And this describes the development of the SSI toddler and the SSI preschool scales that you have in your handouts. So the study objectives were to evaluate the validity in terms of the construct and in terms of its diagnostic capabilities. So we're going to go into each of these sets of results on their own, so we won't dwell too much on this right now, but we wanted to look at the factor structure in terms of what constructs we were actually measuring in the instrument, and in terms of convergent validity. And again, this is how well the screen relates to other measures, other diagnostic measures, other adaptive behavior measures, to see what kind of overlap there might be with those. And the diagnostic validity was looked at in a number of different ways in terms of the full scale, the subscales, and the items. And all the diagnostic validity idea is just how well does the screen identify people in different groups, because you want it to be able to do that, since that's its purpose. And another goal was to refine it as a screen in terms of younger versus older participants, and to shorten the scale to make it a nice palatable size and a good, efficient size. And then, of course, to, as part of this process, to obtain cutoff scores. Okay, so a quick overview of the methods. And the study participants are described in one of the tables that you have as well. I think it's the first page, if that's of interest to you. And there were 420 children from age 2 to age 5. And this included 114 individuals with autism or PDD-NOS, 138 with other types of developmental or psychiatric concerns, and 168 typical controls. It was administered in specialized or developmental clinics and pediatric offices. And again, these data were collected in the Kennedy-Krieger area. And so it's completed by the caregiver. In terms of this study and probably many others, it was mostly the mother. I think over 80% of the time it was the mother as the informant. And other diagnostic, IQ, adaptive behavior, the measurements were completed for a number of the individuals across the clinical and across the autism and the other clinical groups. Okay, so the last slide before we get to the actual results for you. We looked at the distribution of the data, which is important for some of the statistical techniques that you do, and it was normally distributed, which in and of itself is important for an instrument that we would want to see that in. We want it to be continually distributed through the population. And there were no significant outliers. And as far as the evaluation of construct validity, we conducted exploratory factor analysis with all of the clinical participants. This created a nice, robust, and varied group for the factor analysis. If you're familiar with those procedures, that's the best practice for that. And again, convergent validity and subject characteristics. And as I mentioned before, we looked at the diagnostic validity in terms of both two age groups, the youngers, which we're calling the toddlers, and the olders, the preschoolers. And we did several steps for diagnostic validity, looking at the full scale, the subscales, the individual items, and in a number of different ways. And finally, doing receiver-operator characteristic curves in order to determine levels of sensitivity and specificity. The results listed here are also in your tables, I believe, tables 2 through 4, if you're interested in those. And the factor analysis was conducted looking at 3, 4, 5, and 6 factors, and we chose the 4-factor solution as the best fit for the data. And we labeled the subscales as follows. My mouse going here. Connection with caregiver, and this relates to affection, interaction with the parent, greetings, how the child behaves at mealtime as far as interaction goes, and kind of shared excitement about things is usually within the caregiver-child interaction. And the interaction imagination subscale we labeled as such because it included pretend play type of items, interaction with other children, and mimicking behaviors of the child of other adults. And this interaction imagination scale was actually very robust across the analyses that we did, and so that was a really interesting finding for the scale. The social approach or interest scale included items related to the child's approach of others, obviously, and being interested in engaging in play. The agreeable nature items, this factor captured a lot of those items that we mentioned were kind of the potentially stigmatizing type of behaviors that some children may do, and as far as irritability, and then how the child is perceived by others. The convergent validity looked good. You want to see some overlap with related measures, but you don't want to see a replication. So this is a good level for the relationship with the ADIR and with the CARS as well. And interestingly, well, actually, it makes sense that with the CARS, there are a lot more items related to repetitive behaviors and different types of not directly social communication. So that it's not surprising to see this level here It's still significant, but it's lower. Okay, we'll just look at this quickly because we're going to see it in more detail here in a moment. And the rest of this material will cover the results of the diagnostic validity. Again, how well the screen identified different groups of individuals. And these two sets of results are also in your packets, tables 5 and 6. The ANOVAs are just basically the group comparisons. And these were very encouraging at the full-scale level as well as the subscale levels. So we'll look at that in a moment. And the binary logistic regressions, these were conducted in order to determine critical items, items which best predicted a child's membership in the autism spectrum group or the non-autism spectrum group. So that's what that relates to. And if you have any questions about any of the procedures, the rationale for the statistical procedures, you can ask me later, or the paper has been submitted for publication, but it's not yet published. So, okay, so looking at these group comparisons, and I'm sorry, these are, well, I guess you can see it. It's kind of small, but what you notice is that there's a nice main effect here for the total score. In the autism group, the mean SSI score was 71 versus 124 in the typically developing group. And another thing that was exciting here is that the discrimination among all 4 groups was significant. We did some a priori contrasts and found that each of these was significantly different from the next. So the autism versus PDD-ONOS versus non-ASD clinicals versus typically developing. And we saw this pattern also with the interaction imagination subscale. Again, as I mentioned before, that's found to be a robust subscale. So that differentiated each group from one another as well. And most of the others had good differentiation too. The least powerful, if you want to say it that way, is the agreeable nature in terms of discriminating the groups. So this was our first look at how well it identifies different children. And as I mentioned, we did the binary logistic regressions to determine critical items. So for the toddler age, the 24 to 42 months, these are the items. And the italicized ones are shared with the preschool scale. So you'll see that on the next slide, italicized as well. And all of these items together will relate to interaction and play, joint attention, understanding affect, other people's emotional displays, and showing interest in other people. So we're seeing that pattern across these scales, but and what we also notice here with the preschool, with the seven critical items here, also relating to the same concepts, but noticing a little bit higher level of skills showing up in some of these critical items in terms of the older children's ability to start a social interaction. And it also includes a pretend play item that was not a critical item for the younger children.
Sarah, I'm wondering if you could define for people what you mean by critical items, like what are you looking at, so differentiating each item whether the child is ASD versus non.
Yes, thank you. And these critical items are those that were found in a regression model to best predict, are you in the autism group or are you not in the autism group? So all 54 SSI items were loaded in together and were removed one by one. And those that we chose those that were left that were important to the regression model. Sorry, it's a little statistical, but by removing these items, it would have had a large effect on the model. So basically, it's just that, despite all that, it's just meaning that these best predicted the child's membership in the autism group versus the non-autism developmental disability group. And, well, I'm misstating it a little bit. It's the autism and PDD. It's the autism spectrum disorder group versus all other non-ASDs. And the details of the binary regression are also in your tables. Okay, the final analyses related to honing the scale and getting cutoff scores. So we found these critical items, but we want to make sure that if we have other items around it, that they're also powerful items. So we did this through looking at individual item t-tests and intercorrelations of items. So we looked at how well, just like with the group comparisons with the ANOVAs, we looked at each item individually to see how well they differentiated. And then we looked for the intercorrelations. Here we go. We looked at overlap, because if we have two items that are basically measuring the same thing equally well, we're trying to have a screening instrument. We don't want to have extra items that we don't need. So we eliminated a few items that way as well. And so we ended up with the shortened instruments of the SSI toddler with 26 items and the SSI preschool with 21 items. And we needed to look at receiver operator characteristics, which is basically it's a procedure that you pick a cutoff score and you for your measure, and you look at sensitivity and specificity or accuracy, how well your items predict group membership. And we'll look at this here at the next slide, but overall the levels were good for all the different comparisons that we did, at or above 0.79 for sensitivity and at or above 0.64 for specificity. And higher, a bit higher for the kind of the most key comparisons that we looked at, and that's summarized here. For the SSI toddler, for the younger children, using a cutoff score of around 45 to 48, you're getting pretty nice levels here, 0.87, 0.80, 0.7 range. And again, these are, in a way, you choose your what's important to you. So you can choose a cutoff that will provide a very high specificity here, but then you're going to get a lower sensitivity. They're reciprocally related. So with screening instruments, we tend to value sensitivity a little higher because you want to catch the positive cases. And we take it a little less, we don't mind catching a few false positives with the specificity level. So, okay, we did include a matched subsample, which is very important if you can whenever you can do that in your work. And this was based on age and IQ level. We matched within 6.5 months of age, and within 12 IQ or developmental quotient points. We had 20, and I'm sorry the ends are not on this particular slide, although you do have this in your tables. I believe it's the last page of your tables, page 7. But there were, let's see here, 20 younger children in the matched sample and 34 older children in the matched sample. And so looking at, one thing you notice right away between the unmatched and the matched is that these levels are really almost identical, which is very encouraging. I mean, there's a little bit of difference, but they're pretty similar. And when we went to choose a cutoff, we decided to kind of go with the mean of the unmatched and the matched samples. So, having said all that, this leads us to take a look at this, and I know it's a little bit hard to see the details here, but just to get an overall view, what you're looking at is with using a cutoff score of 47, which is this dotted line here. Oops. Haha. This is all of the children in the receiver operator characteristics group that was done with the toddlers, 73 children. And everyone below this 47-point cutoff are screened as positive for being at risk for ASD, or for the social delays related to ASD. And everyone to the right of the line is screened as not at risk. And it's always of interest to kind of wonder who gets miscategorized here. So looking at these, if you see the darker lines here, the autism and PDD and NOS on the right side, these false negatives tended to have lower ADIR scores, so lower diagnostic characteristics, and somewhat lower IQ scores. Now the N is pretty small to be able to analyze this, but that's just the trend that we found with those false negatives. And looking at the other group, using a cutoff score of 40, again, everyone depicted to the left of the line is determined to be at risk for autism spectrum disorder, and everyone to the right was determined to be not at risk. And these false negatives, the darker ones you see here on the right, which are 9 of them, also tended to have lower autism diagnostic inventory scores, the diagnostic scores. And they almost all of them, I think it was, almost all of them had PDD-NOS. So they had lower autism symptoms to begin with. So that's why that accounts for why some of these children were missed, essentially. Okay, so another very wordy slide for you. Basically, we found a good factor structure with very interpretable factors. The SSI was related moderately to the diagnostic measures that were also done, so that's a good finding. The scale and the items were predictive of diagnostic group, which is definitely a good thing because that's what we're looking for. And we identified an interesting and powerful subscale with the interaction and imagination items that will be potentially interesting as time goes on. And good sensitivity and specificity, or the level of accuracy, with both the matched and the unmatched groups of participants. And we were able to produce shortened scales for both the younger and the older children. So you have hard copies of each scale and the scoring templates for each scale as well. If you don't have them, they're out in the hallway. So just to kind of talk a little bit also about some of the clinical advantages of the screens, the 4-point scale, instead of the pass or fail scale, allows for finer tuned discrimination. It's just more powerful. The more you have to measure, the more powerful your measure is, and that's kind of seems to be the way that screens are moving in that direction for the autism screens. They're mostly a positive valence, and what I mean by that is that they mostly measure typical behaviors. So when a parent looks at the screen, it looks kind of friendly. It doesn't look like asking a lot of things, strange things that your child does. It's kind of looked at in the other direction of, are these typical behaviors present in your child? So it's as far as acceptability to parents, they've found it to be acceptable. Items are easy to understand. And the scales are a pretty good length at this point. And, you know, it's focusing on the primary cardinal feature of autism spectrum disorders. And like I said, it's still a hypothesis, but, you know, not including some of the repetitive and ritualistic behaviors may help improve the accuracy of this type of screening. And just to mention with this, future directions, we would want to look at the factor structure again, just to replicate that. That's always important, as well as the identification of the critical items with different samples, different research samples, and possibly the effect of verbal ability and cognitive ability on the clinical utility of the instrument. Okay, and the original research was supported by a grant to Dr. Guman, and all the researchers are grateful to the families who volunteered to take part in the studies. And finally, if you want more information or you want electronic copies of the instrument, you can contact Dr. Guman in this way. And this is my contact information if you want to contact me as well. So, thank you. Do you guys have any questions?